So welcome everyone. Thank you for attending tonight. This is the August Radicle Community webinar. My name is Timothy Byars. I'm the president of Radicle Health, and as always, I'm joined by our CEO, Eloise Theisen. I'm going to warn everyone that my iMac died about 15 minutes ago, so I'm using an old laptop, and it might be a bumpy ride here today. The Radicle community is comprised of advocates and educators and healthcare professionals, cannabis stakeholders. And what we want to do is we want to provide support, information, and resources to all of our members. So for information about how to join the Radicle community, you can go to our website, radiclehealthcare.com, click the community link there. And when you sign up, you get access to a couple of seasonal newsletters that we put out. We also have an on-demand video library. It includes all of the recordings of these webinars, as well as some additional interviews and other media. It's free to sign up, and there's no cost associated with being a member. It just simply adds you to our email list. So if you're interested, go to the website and sign up. I also want to remind everyone that we have an array of curriculum options at a range of price points for both students and working professionals. So whether you are somebody who's helping customers make good product choices, or maybe you're a healthcare professional who's treating patients, maybe you're somebody who is advocating for social change, or maybe you're just simply using cannabis yourself, you need evidence-based, factual information about cannabis. And Radicle Health curriculum is up to date, it's comprehensive, and it's informed by both clinical expertise and by instructional design expertise. So please reach out to us for more information, or you can go to the website and click on the education link. So the presentation today is for educational purposes only, and the information presented today is not intended to be a substitute for medical advice. This information is not meant to help in the diagnosis, prognosis, or treatment of any disease, virus, illness, or condition. If you are using cannabis as a medicine, please work with an experienced cannabis clinician. All right, so today we are talking about cannabis and immunotherapy. And over the last decade, there's been a significant increase in the research and the use of immunotherapy and cannabis for the treatment of cancers and cancer-related symptoms. And these two immunomodulatory modalities likely interact. So it's important that we understand, both as clinicians and as potential patients, how the use of cannabis might influence both the mechanisms and the efficacy of immunotherapy. I want to warn everyone at the onset that this is a complex topic. It does require some understanding of the immune system, which is, largely outside of the scope of this talk today. We will, however, cover some fundamentals about how the immune system works, how immunotherapy works, and then also we'll talk a little bit about how cannabinoids act as immunomodulatory agents. So let's start with a brief immune system review. The immune system is, of course, comprised of a complex network of organ systems and tissue groups, proteins, and all of these things help the body defend against infection and cancerous cells. An immune system functions and processes, and we might refer to these as immunosurveillance, our own body's immunosurveillance. These occur through complex relationships among the bone marrow, thymus, lymph nodes, the spleen, the skin, our mucous membranes, and then a whole diverse number of white blood cells, antibodies, and antimicrobial proteins. So more broadly, we can take all of these things and we can kind of group them into a few different categories. And the first category, of course, is it's a physical barrier. It's our skin, our largest organ of the body, and our mucosa, which lines the mouth and the nose and the respiratory, digestive, urinary, and reproductive tracts. And of course, these barriers are not only physical; they both produce or contain chemical defenses that can destroy external pathogens. So, for example, acid can be produced by the skin, the stomach, and by vaginal secretions, saliva, sweat, mucus, eye fluid. They all contain bacteria-destroying enzymes. And then skin cells produce and secrete important antimicrobial proteins. And there are immune cells that can be found in specific layers of our skin. So that's kind of the first category of, very broad category of the immune system. And then we have our innate immune system. This is really the body's first line of defense against germs entering the body. And the innate system responds in the same way, regardless of what the foreign substance is. And this is why it's sometimes referred to as the non-specific immune system. And of course, when we think about the immune system, we think about white blood cells, right? So all white blood cells are types of leukocytes. And most of these cells operate in the innate system. And so, we can say that the innate system includes these specific types of white blood cells, but also antimicrobial proteins and other types of cells that identify, attack, and remove foreign substances. And internal innate defenses also include the production of fever and also the release of chemical signals. We'll talk a lot about cytokines today, and then also the production of inflammation. So when a foreign substance is detected by our immune system, the first white blood cells to appear are usually phagocytes. And this is a name that's derived from the Greek word to eat or devour, and then it's combined with the suffix "cyte," which just denotes a cell. So phagocytes ingest harmful foreign particles, bacteria. They also ingest dead and dying cells, and they're really essential for fighting infections and also for subsequent immunity. And we have a lot of these things. 1 liter of human blood contains about 6 billion phagocytes. And there are multiple types. So they can be sort of subdivided into white blood cells called monocytes and macrophages, neutrophils, tissue dendritic cells, and also mast cells. And we're going to talk a little bit about a couple of these. So neutrophils, the most abundant of the white blood cells, they're located mostly in the bloodstream. And then during inflammation, neutrophils are among the first types of cells to migrate toward the site of inflammation. And these cells can migrate through the blood vessels and then also through interstitial tissue, so the area that's between the cell and the capillary bed. We also have natural killer cells. So in addition to having the coolest name of all white blood cells, these are cells that circulate in the blood, and they're also among the body's first line of defense against viruses and certain types of cancers. Natural killer cells sort of straddle the boundary between the innate immune system and the adaptive immune system, which we'll talk about a little bit later. They are part of the innate, but they have a mechanism that's sort of similar to some white blood cells that are actually part of the adaptive system. Macrophages, these are larger white blood cells. They can actually move out of the bloodstream and occupy tissues, and they can engulf and digest substances that lack a certain surface protein marker that are specific to healthy cells. And we're going to talk about what those markers are later. So macrophages can engulf things like microbes and cellular debris, foreign substances. They can be used in immunotherapy, but we're going to really focus on adaptive immunology and T cells today. And that sort of brings us to that last category that I'm going to talk about, which is the adaptive system. So the adaptive system is also called our acquired immune system. This includes specialized cells and processes that also eliminate pathogens. The adaptive system is unlike the innate system because the adaptive system has the ability to remember specific pathogens. So anything that the immune system has previously encountered in the body, it can kind of remember and prepare for those pathogens in case there's a future encounter. So this is sort of an immunological memory that facilitates an enhanced response to any subsequent encounter to the same pathogen. So this acquired response is called adaptive, again, because it prepares the body's immune system for these similar future challenges. It can also be maladaptive when it results in things like allergies or autoimmunity. We'll talk a little bit about that in a few minutes. The white blood cells in the adaptive system are called lymphocytes, mostly because that's where they do their most of their work in the lymph or in the lymph nodes. And they can really be divided into multiple types of cells as well. So we have, for example, B cells. And B cells produce antibodies. And when we talk about antibodies, they're simply just proteins that travel through the bloodstream and they selectively bind to foreign antigens. So when I say antigens, really what I'm talking about is any substance that's going to elicit an immune response. So antibodies can block antigens from entering host cells. They can kind of they can glom on to antigens and tag them so that other immune cells like macrophages can come along and destroy the antigen. And each type of antibody is unique and it defends the body against one specific type of antigen. And then again, we should note here that antibodies can be produced when the immune system mistakenly considers healthy tissue a harmful substance. And this, again, this is what happens in our immune disorders. And then we have T cells. So when we talk about T cells, the T stands for thymus. And they're called T cells because these cells actually mature in the thymus. All white blood cells are made in the red bone marrow. Some of them mature there, but T cells actually travel to the thymus and they mature in the thymus. So T cells can recognize antigens, again, to which the immune system has been previously exposed. T cells can also be divided into a couple of different categories. So we can talk about three types of T cells, actually. We can talk about T helper cells, T cytotoxic cells, and T memory cells. Sorry, I actually advanced one slide too quickly, but that's okay. I'm just going to stay here. So the first type of T cell that we have is a T helper cell. And these are called CD4 positive helper cells. And so what these do mostly is they activate B cells. So when you have a B cell, it can mature, but it's not activated yet. So the T cell can help, the helper T cell can help activate it. And that enables the B cells to produce additional antibodies and also macrophages. So CD4 positive helper cells, they're called naive when they have matured, but they haven't actually encountered their associated antigen, and they're specific to one antigen. And also CD4 positive helper cells can also help activate CD8 positive cytotoxic cells. That's the second type of T cell that we'll talk about. So CD8 positive cytotoxic cells, they kill other cells. So that's what cytotoxicity is. It's the killing of a cell. So these cells, these kinds of T cells can kill infected cells that have been infected by either viruses or by cancer. So similar to the helper cells, CD8 positive cells are called naive when they've matured, but they haven't been activated because they haven't sort of met their associated antigen. And I don't have a slide for it, but memory T cells, these develop when naive T cells encounter a specific antigen, and really memory T cells are, they're facilitating a faster and more robust immune response during future exposures to an associated antigen. And just for the sake of clarity, when we talk about CD8 cells, CD8 positive, CD8-4 and CD8 positive cells, the CD part of it, it stands for cluster of differentiation. And it's just really a naming protocol that's used to identify cell surface molecules. All right, so today, within the context of immunotherapy, we're mostly going to limit our discussion around adaptive immunity. So, this is, in most cases, this is the immunity that provides long-lasting protection. And sometimes for a lifetime, not always, but sometimes, and for some conditions and diseases. So, for example, if you've recovered from measles, for example, you're probably protected from measles for your entire lifetime. Now, not all diseases are like that, but some are. And when we think about cancer specifically, cancer begins with a mutation in a gene. So in other words, cancer is different than like a bacteria or an antigen that's floating around in the bloodstream or in the extracellular fluid, right? Cancer exists inside of a cell. So we want to focus mostly on the part of the immune system that's cell mediated, the cytotoxic part of it, the CD8 positive T cells, because these are critically important to cancer immunotherapy. And again, there are many, many types of immunotherapy, and Eloise is going to talk about multiple types. We're going to focus on the kinds that we're going to focus on adaptive immunity with respect to immunotherapy. So one last bit of immune system review. We want to make sure everyone has a good understanding of the concept of apoptosis. So when we talk about cell death, there are really two broad ways that cells can die. They can die. The first way is that they can die from either a physical or a chemical injury. So, a cell, for example, might be deprived of oxygen. That's kind of a chemical injury. Or a cell membrane might be damaged from a virus. Or there might be a protein that the body is producing that punches a hole into the cell membrane and allows a bunch of extracellular fluid to flow in, and then the cell bursts. So, these physical or chemical injuries can lead to things like cell disintegration or necrosis. The second way, that very broad way that cells can die, are just through programmed cell death. And this is called apoptosis. And apoptosis is a normal part of cell life cycle. So every cell, cells are developed, and then they divide a whole bunch of times, and then they go through a programmed cell death where effectively they just simply destroy themselves from within, and they degrade themselves through various mechanisms until nothing is left. And you can see on the slide here, sort of these two functions, right? The bottom, the blue arrow, is through necrosis. And then you can see the top arrow, as it goes through apoptosis, it goes through this function called blebbing, where it sort of starts to break apart in these little bubbles. And then finally, they're so small that they get eaten up by macrophages and other immune cells. And this is kind of a 3D conceptual image of a cell going through blebbing, which is a great word also, blebbing. All right, so we're going to focus on, we're going to focus on cytotoxic CD8 positive T cells, which kill their targets by programming them to undergo apoptosis. And cytotoxic T cells express specific receptors that recognize one antigen. And again, antigens are molecules that stimulate an immune response. And the ones that we're interested in today are produced by cancer cells. So one method that a T cell uses to identify a cell that's damaged or infected is by looking at the cell's MHC1 receptor. Every nucleated cell in our body has an MHC1 receptor, and it stands for major histocompatibility complex. So in a normal cell, the MHC1 receptor will express a self-antigen. It'll have a little part of itself kind of lodged into that receptor, and that could be like a small protein or a peptide. But in a foreign cell or in a damaged cell, there's going to be something wrong with that receptor. So in a foreign cell, it's going to have a foreign antigen, something that our body doesn't recognize. And in a damaged cell, there's going to be something wrong with it. There might be maybe a self-antigen that's normal to a healthy cell, but some foreign antigen that's clomped on, like a virus that has produced a protein that's kind of glommed on to that antigen. And so this is going to be important later when we talk about cannabinoid interaction with immune systems. So if the T cell can bind to this antigen, because we don't want our T cells binding to healthy cells, right? But if the T cell can bind to one of these antigens, then that's when the process of apoptosis starts to occur. That's when the cytotoxic CD8 positive T cell will start to kill that cancerous cell or that infected cell. All right. So the binding of those T cells to the MHC1 antigen also relies on the binding of a glycoprotein called CD8. And the T cells that express this glycoprotein are the CD8 positive T cells. That's how they get their name. They've got this protein that comes off the surface. It's a glycoprotein called CD8. And the affinity between the CD8 protein and the target cell keeps the T cell and the target cell bound closely together so that the T cell can work its magic and make sure that there's this antigen-specific activation. All right, so I know that that's a bit heavy. It's a little bit of a review for the immune system. Basically, all we need to get started for the rest of our discussion. So at this point, I'm gonna turn it over to Eloise.
Thank you, Timothy. Yeah, the immune system is quite complex, as is the endocannabinoid system. So we have two pretty complex topics, which I think is really what brought us to want to do this topic on immunotherapy and cannabis, because there's a lot of questions out there. So we're going to transition into immunotherapy, as Tim mentioned. And first, I want to cover the types of immunotherapy treatments. So we'll review the most common types of cancer treatment protocols. And for the healthcare professionals here, you may recognize some of these. We know that many cancers are currently treated with a combination of chemotherapy, radiation, and surgery. So our chemotherapy targets fast-growing cancer cells, but it also damages our other healthy cells in the body. That's why we see all of these common side effects: hair loss, diarrhea, nausea, rashes, fatigue, mucositis, bone marrow suppression. Radiation will target cancer cells in a specific area by using radioactive particles. And while it can be directed at a fairly specific area, the process can also damage other healthy cells. So we'll see in our patients fatigue as the most common side effect, but other side effects can vary depending on the area of treatment. So for example, in our patients that are receiving radiation treatments aimed at the stomach, they might experience some nausea. They might also get some mucositis. And they may be receiving, those that may be getting radiation directly to their chest might actually experience some difficulty breathing as well. And surgery can be performed to remove the cancerous tumors or tissues. Sometimes they're able to get it all. Sometimes there's some residual tumor left. Sometimes we give the chemotherapy first to try to reduce the tumor burden and then perform surgery. And some of the side effects related to surgery can include pain, fatigue, swelling, numbness, and of course, the risk of infection. So with immunotherapy, it is a cancer treatment and it manipulates the body's immune system to prevent, control, and eliminate cancer. And immunotherapy treatments intend to, 1, prime the immune system to recognize and attack specific cancer cells, 2, boost immune cells to help eliminate cancerous cells, and 3, enhance the immune response. So using immunotherapy enables treatments that specifically target cancer cells and spare healthy cells. So this is how we're hoping to treat it with less systemic side effects. And because the immune system can adapt and remember specific cancers, the immune system can target and eliminate a cancer if it returns. So using the immunomemory ability of immune cells might help facilitate long-lasting and potentially permanent protection against the recurrence of cancer cells. And it's no surprise that we're seeing a large amount of immunotherapy being offered to our patients. By December of 2019, the FDA had approved immunotherapy treatments for 20 different types of cancers, and we expect to see this grow. There are many different types of immunotherapy. So for example, immunotherapy treatment can include the use of antibodies, cancer vaccines, adoptive cell transfer, tumor infecting viruses, checkpoint inhibitors, cytokines, and adjuvants. And some immunotherapy treatment protocols include the use of multiple types of immunotherapy. So we'll briefly look at each of them. Antibodies are the Y-shaped proteins that bind to foreign substances in the body. Typically, these will include things like viruses, bacteria, fungi, or parasites. Our natural antibodies are created from plasma cell factories and released into the body. When they bind to a foreign substance, they can trigger molecular events that eventually kill the pathogen. There exist various types of antibodies and they perform different functions. So for example, some neutralize pathogens directly, others will tag the pathogen or wrap the pathogen in a coating so that other immune cells can identify and kill the pathogen. Monoclonal antibodies are made in a laboratory, and these antibodies can boost the efficacy of natural antibodies and perform the same function as natural antibodies. We're actually seeing this being used a lot right now for COVID. In cancer treatment, monoclonal antibodies can block the activity of abnormal genes, proteins, or tissues in a tumorous event. Some monoclonal antibodies can also inhibit immune checkpoints, which are discussed below. Vaccines are biological preparations that provide immunity to a specific infectious disease. Vaccines usually include some substances that have similarities to a microbe. So for example, a vaccine might include weakened or dead forms of a microbe or some subset of the microbe's surface proteins. The vaccine initiates the immune response to the microbe so that the immune system can later recognize and destroy the microbe during any future infections. Vaccines are either prophylactic, meaning they can prevent or ameliorate effects of a future infection, or therapeutic, meaning that they fight an existing disease such as cancer. Adoptive cell transfer, also called T-cell transfer therapy, involves the identification and removal of the most effective T cells from the patient's blood or tumor tissue. These T cells are then replicated in a laboratory and then given back to the patient to help facilitate the immune response to the cancerous tumors. And tumor-infecting viruses, also known as oncolytic virus therapy, can be used to treat some cancers. Some viruses simply kill tumor cells. Also, when viruses infect and damage cells, the dying cell can release signals to enable the immune system to recognize the infected cell. This mechanism was observed first in the late 1800s, when doctors observed that some cancer patients went into remission after a viral infection. While only one oncolytic virus is currently FDA approved for treatment, there exist several dozen viruses, as well as some strains of bacteria that are currently being studied as potential cancer treatments. And cytokines, they're small proteins that cells release to facilitate communications among cells. And there are multiple types of cytokines, including lymphokines, which are produced by our lymphocytes, and those include natural killer cells, T cells, and B cells. Monokines, which are produced by our monocytes, which include macrophages and conventional dendritic cells. Chemokines, which attract white blood cells to infection sites. And interleukins, which are important for stimulating immune response. Cytokines can act on nearby cells, on distant cells, and even on the same cell that released them. And some cytokines can promote inflammation, and some cytokines can inhibit inflammation. Some cytokines facilitate pain sensations by directly activating nociceptive neurons, and some cytokines can contribute to hyperalgesia and allodynia, increased pain from a stimulus that usually provokes pain, and increased pain from a stimulus that usually does not provoke pain, respectively. And adjuvants. They are ingredients added to vaccines to promote more effective immune responses. Very few modern vaccines include an entire virus or bacteria. Most vaccines include a component or subunit of a germ, such as a specific protein. Adjuvants can help produce an immune responses capable of protecting a person from the targeted disease. And finally, we have our immune checkpoint inhibitors, and they block the binding of proteins presented on T cells to damaged cells. Immune checkpoints are part of the immune system. In a normal functioning immune system, immune checkpoints prevent overly aggressive immune responses that destroy healthy cells in the body. These signaling pathways are natural pathways that help tune down immune response after the elimination of disease. These negative signaling pathways help prevent too strong an immune response, which can damage or kill healthy cells, and prevent immune response tolerance, especially preventing T cells from recognizing your own body and causing autoimmunity. Tumors can express specific peptides or proteins on the tumor surface, creating signaling pathways that send messages that tell T cells to migrate or even completely stop the immune response. One pathway that tumors use includes a receptor called programmed death 1, also known as PD-1, which is expressed on the surface of immune cells, and a ligand called programmed death ligand 1, PDL1, which is expressed on the cancer cells. So when PDL1 binds to PD-1, the binding sends a message to this T cell to mitigate or even completely stop the immune response. These messages trick the immune system and enable tumors to avoid detection, making the tumor invisible to the immune system and allowing the tumor to grow unchecked. Immune checkpoint inhibitors blocking the binding of these proteins between T cells and damaged cells. This blocking mechanism prevents what is effectively an off signal from being sent by the tumor to the T cell, which enables T cell to continue killing the damaged cells. Clinicians can now use specific blocking agents that prevent PD-L1 from binding to PD-1. This therapy does not kill cancer cells directly. Rather, it disrupts the specific receptor pathway that enables tumors to hide from immune system. Two of them are pembrolizumab and nivolumab are two examples of anti-PD-1 immunotherapies. I'd really love to be in the room when they come up with these names so I could understand their rationale behind these names. I know the MABs have an origin in either mice or human, but the rest of it I don't understand. I digress. The use of checkpoint inhibitors is a paradigm shift in cancer treatment protocols in that this approach does not actually target cancer cells or tumors and does not turn on or stimulate the immune system. Rather, this approach enables the immune system to work more efficiently and effectively. And the side effects of immunotherapy are much different than those from chemotherapy or radiation. Immunotherapy is going to stimulate the immune system. So the adverse effects can range from minor inflammation and flu-like symptoms to potentially life-threatening autoimmune disorders. The most common side effects include skin reactions, mouth sores, fatigue, nausea, body aches, headaches, and changes in blood pressure. And so while the conclusions in the medical literature are not conclusive, they seem to suggest that cannabis use during immunotherapy correlates with poor clinical outcomes. In one retrospective observational study, researchers compiled all relevant data from patients treated with nivolumab between 2015 and 2016. This included a total of 140 patients. 89 of whom who used nivolumab alone, 51 who used nivolumab with cannabis. These patients were all diagnosed with advanced melanoma or small cell lung cancer or renal cell carcinoma. The response rate represents the proportion of patients who have a partial or complete response to therapy. Overall, across all three types of cancers, the response rate in the nivolumab only group was 37.5% versus 19% in the nivolumab and cannabis group. 28 patients in the nivolumab and cannabis group received second-line immunotherapy treatment, and 22 patients received the protocol as a third-line treatment. So these were clearly very sick patients who didn't have great life expectancy to begin with. 29 of these patients in this group also smoked tobacco, with 56% of the total patients versus a total of 40% of smokers in the group that used nivolumab alone. It's important to note that overall response rate to immunotherapy is actually higher among current and previous tobacco smokers than in non and never smokers. Tobacco smoking promotes greater expression of the PD-L1 on tumors, which subsequently facilitates better outcomes when using anti-programmed cell death protein 1 therapy, especially in patients with advanced non-small cell lung cancer. In this study, the patients in the nivolumab only group diagnosed with non-small cell lung cancer had a 33% response rate versus a 17% response rate in the nivolumab and cannabis group. And patients in the nivolumab only group diagnosed with melanoma or renal cell carcinoma had a 43% response rate versus a 10% response rate in the nivolumab and cannabis group. Researchers concluded that the patients not using cannabis were more than 3 times more likely to respond to the treatment, although they saw no differences between the two groups in overall survival or progression-free survival rates. And curiously, the percentage of THC and CBD did not impact response rate. And paradoxically, patients using higher levels of THC had better response rates to immunotherapy. These products that were used were tested and divided into 4 groups for analysis: THC greater than 10%, THC less than 10%, CBD greater than 1%, and CBD greater than less than 1%. The dosages range between 20 grams to 30 grams per month. And in a second clinical study, cancer patients receiving immunotherapy and using cannabis showed a significant decrease in time to tumor progression. And this group had a decreased overall survival compared to patients receiving only immunotherapy. This was a prospective observatory study with 102 patients with advanced cancers receiving immunotherapy. 68 received only immunotherapy, and 34 receiving immunotherapy and used cannabis. The cannabis group included 24 males and 10 females. 8 of the 34 were receiving first-line therapy, and 26 were receiving second-line therapy. Patients were receiving treatment for non-small cell lung cancer, melanoma, and renal cell carcinoma. In the cannabis group, 71% used 20 grams per month of cannabis, and 29% used 30 to 40 grams per month. 67% of cannabis users had low lymphocyte count versus 51% in the immunotherapy-only group. The median time to tumor progression for cannabis users was 3.4 months versus 13.1 in the immunotherapy-only group. Overall survival in the cannabis group averaged 6.4 months and 28.5 months for the immunotherapy-only group. Unsurprisingly, cannabis-using patients had fewer immune-related adverse effects than patients who did not use cannabis. And recall that the side effects of immunotherapy are different than chemotherapy and can even be severe or fatal inflammation-related reactions. So for example, researchers observed no instances of colitis in the cannabis-using group versus 9% in the immunotherapy-only group. Skin toxicity was observed in 6% of the cannabis users versus 13% in the immunotherapy-only group. And treatment-related adverse effects were associated with a 5-year overall survival rate. This study suggests that immunotherapy can affect the levels of detectable endocannabinoids. The 2 groups showed no differences in endocannabinoid levels in the serum before immunotherapy. However, the levels of 4 endocannabinoids were associated with overall survival time. 3 demonstrated an inverse association with overall survival expectations. Higher concentrations of endocannabinoids correlated with lower overall survival, and 1 had the opposite association. The researchers concluded that endocannabinoids might be used as potential clinical markers for predicting patient response to immunotherapy. I'm going to go ahead and turn it over to Timothy now to go into the endocannabinoid system and the immune system.
Thanks, Eloise. Okay, so we now have some idea about how immunotherapy works, and we have some literature that suggests that cannabinoids might actually be antithetical to immunotherapy. But we want to look more closely at the specifics, and we'll do so with this caveat. Again, we both stress this. The immune system is complex. The endocannabinoid system is complex. The interaction of cannabinoids and the immune system is complex. And some of these mechanisms that we're discussing today are not well elucidated in the literature. And of course, I have my own limitations on the understanding of some of these mechanisms. So just keep those caveats in mind. So we all know that the ECS regulates multiple physiological processes, especially immune function and inflammation. Immune cells express CB1 and CB2 receptors. There are estimated to be about 10 to 100 times more CB2 receptors expressed on immune cells than CB1. So it seems like CB2 receptors are more important in immune response. We know that multiple cannabinoids have demonstrated potent anti-inflammatory, immunomodulatory, and also analgesic effects through the cannabinoid receptors, through CB1 and CB2 activation. Most of the research, of course, includes THC and CBD, so we're going to limit our discussion to those two cannabinoids. So THC can directly affect immune cells through CB2 receptor activation, and CB2 receptor activation via any CB2 agonist, including THC, can inhibit inflammatory response and has therapeutic potential for the treatment of things like MS, ischemic injury following stroke, rheumatoid arthritis, inflammatory bowel disease, inflammatory autoimmune diabetes, spinal cord injury, sepsis, osteoporosis, inflammatory pain. All of this is well established in the medical literature. So we know that THC has immunosuppressive effects. So what about CBD? Well, despite having very little binding affinity with either cannabinoid receptor, CBD is also involved in mediating inflammatory response. And studies have suggested that CBD probably has anti-inflammatory effects via several receptors. So for example, just like THC, CBD inhibits adenosine uptake. So activation of A2A receptors has anti-inflammatory effects. CBD is an antagonist at GPR55. So when GPR55 is activated, it has pro-inflammatory effects. So as an antagonist, CBD is going to inhibit that pro-inflammatory effect. CBD is a full agonist at the serotonin 5-HT1A receptor. So many immune cells express 5-HT1A. And one study suggested that interleukin signaling, and remember that interleukins are sort of a subcategory of cytokines, that interleukin signaling can be inhibited by CBD activation of 5-HT1A receptors. So CBD also is immunosuppressant. So subsequently, we have this kind of prevailing consensus that cannabis is, or specifically that THC and CBD, both are immunosuppressant. In fact, the manner in which cannabinoids impact the humoral immune system, so when we talk about humoral immune system, we're talking about like the effects of the immune system on things floating freely in the lymph and the blood. The effects of cannabinoids on that part of the system might actually benefit patients undergoing immunotherapy. And perhaps this is the reason why in those two studies that Eloise discussed, cannabis users undergoing immunotherapy had far fewer autoimmune-like adverse side effects, right? Less colitis in those patients, less sort of skin inflammatory conditions. Now, recall that in the context of this discussion, we're mostly interested in cell-mediated immunity and cytotoxic T cells. So again, cell-mediated immunity, that's the immune response that doesn't really involve antibodies. It's the activation of antigen-specific cytotoxic T cells. You got these T cells that are cruising around and they're killing infected cells that have cancer or viruses. And they're also producing cytokines as well. But we want to look more closely at how cannabinoids interact specifically with this one kind of white blood cell, cytotoxic CD8 positive T cells, because these are one type of white blood cell that can find and kill tumors as well as infectious disease. So here's what the research suggests. Generally, delta-9 THC seems to inhibit the proliferation and the maturation of lymphocytes to mature cytotoxic T cells, immunosuppressive. In vivo research suggests that THC and 11-hydroxy THC can suppress the killing capacity, the proliferation, and the maturation of cytotoxic T cells. And in fact, cytotoxic T cells are probably inhibited by cannabinoids by a couple of different mechanisms. First, the cytolytic activity of mature T cells is suppressed after the cell binds to the tumor. And then second, cannabinoids might suppress the normal development of those precursor T cells into mature cytotoxic T cells. Again, immunosuppressive. Furthermore, THC might promote T cell exhaustion. So this describes kind of a dysfunction that arises during cancer that's defined by poor T cell function and the sustained expression of inhibitory receptors. Again, immunosuppressive. THC and other CB2 agonists affect dendritic cells, such that the dendritic cells fail to stimulate T cell proliferation or to promote memory T cells. Now, we haven't really talked about dendritic cells, but these are antigen presenting cells that are really instrumental in activating cytotoxic T cells. So very important to the maturation and activation of these T cells that go around and kill tumors. Again, immunosuppressive. In fact, all of these results suggest that cannabinoids might interfere with immunotherapy. And more specifically, they suggest that CB2 agonists might interfere with immunotherapy. Now, recall that in both of the studies described earlier, patients were using between 20 and 30 grams a month of mostly high THC chemovars. So at the high end, that's a gram a day. So maybe it's a dose issue. Maybe there's like a biphasic effect that's happening here. Maybe it's something that can be mitigated. The sort of ill effects of using cannabis and immunotherapy that were demonstrated or suggested in these two studies, maybe it can be mitigated using a different cannabinoid, right? Can clinicians and patients use cannabinoids that don't activate CB2? So that begs the question, okay, well, what about CBD, right? It doesn't really bind to CB2. How does CBD impact adaptive immunity? And there's some good research that has been completed looking specifically at how CBD affects T cells. And here's what that research says. CBD inhibits the production of interferon gamma in T cells. Interferon gamma is another type of cytokine, and it has antiviral and anti-tumor properties. And interferon gamma plays a key role in the activation of cellular immunity and subsequently in the stimulation of anti-tumor immune response. So it's considered potentially useful in combination with immunotherapy for different types of cancer. So immunosuppressive. Interleukin-6, this is another cytokine that's produced by T cells, also suppressed by CBD, immunosuppressive. CBD-mediated apoptosis has been well studied in cancer lines and in primary tumor tissue. And it's pretty well established that CBD can influence anti-tumor immune response and also have anti-tumor activity in a variety of cancer cell lines, including those that have been derived from glioblastoma, breast, lung, prostate, and colon cancer. However, CBD-mediated apoptosis is also a contributor in the immune suppressive mechanism because CBD can induce apoptosis in T cells also, immunosuppressive. Other studies have suggested that CBD can reduce the expression of MHC2 receptors on some antigen-presenting cells, and these are essential to T regulatory cell function. So we talked about MHC1. So every nucleated cell has MHC1 receptors, and they got a little bit of themselves sticking out there. So most T cells ignore it because they're trained to ignore that. And MHC2 receptors often will include these are presented on antigen presenting cells like macrophages and B cells, and they're little bits of foreign matter or antigens that have been scooped up by the immune system and kind of presented to our adaptive immune system so that they can start making more of that specific kind of cell. So critically important to the adaptive immune system, immunosuppressive. So at this point, you might be thinking, okay, we can safely assume that cannabinoids are in fact immunosuppressive, and they're great for treating inflammation, and they're great for treating autoimmune disease, but probably something that should be avoided in immunotherapy, right? Maybe, maybe not. There does exist some data that suggests that the prevailing understanding of cannabinoids as simply immunosuppressant is insufficient, and that cannabinoids can actually demonstrate an immunomodulatory effect that's both adaptive and bidirectional, rather than simply inhibitory. So this is a study from 2014. It suggested that cannabis can actually potentiate immune activity. So in this study, this was done in monkeys. These monkeys were administered THC for 17 months, and then they were injected with an SIV infection. SIV is the simian equivalent of HIV. So these researchers noted that there was an increase in T cells and a reduction in the viral load in these monkeys. Also, the THC also seems to have mitigated intestinal damage that's usually caused by the virus. In a second study, this one in humans, researchers compared the numbers of CD4 positive and CD8 positive T cells in 95 HIV patients. About 25 of these patients were cannabis users. And in this study, the THC positive patients had significantly higher CD4 positive and CD8 positive T cell counts than their THC negative counterparts. So these researchers concluded that THC does not reduce immune function, at least not through T cell inhibition. Now, it's important to note that this study was actually retracted by the journal that published the study. It was in the Journal of Drug and Alcohol Dependence. And unfortunately, they don't, in the retraction notice, they kind of failed to state why the journal's editors thought that the study or the data was flawed. So, take it for what you will. And then finally, remember that we stated that CBD suppresses interleukin-6, that one specific kind of cytokine. Well, interleukin-6 is actually found in high concentrations in tumor microenvironments. In fact, the overexpression of interleukin-6 or IL-6 has been reported in almost all types of tumors. So there's a strong association between inflammation and cancer, which can be measured by high IL-6 levels. And when IL-6 is overexpressed, it seems to promote the survival and proliferation of tumors. Also, IL-6 seems to protect the cancer cells from the DNA damage that occurs during chemotherapy. So there's some research that suggests that blocking IL-6 or inhibiting its signaling, either independently or in combination with conventional anti-cancer therapies, might actually be a potential strategy for the treatment of some types of cancers. So remember that CBD is suppressing this interleukin, and it's sort of again, it's an indirect way in which CBD is potentiating the immune response. So cannabinoids might suppress and they might enhance immune function. And this kind of aligns with our understanding of the bidirectional mechanisms of the endocannabinoid system and homeostasis, right? Cannabinoids might be immunosuppressive when there's a hyperimmune response, and they might potentiate the immune system when the immune system's in a compromised state. This hypothesis is very highly speculative still. There's a lot of work that remains to fully understand the mechanisms of cannabinoids and their influence on the immune system, especially when we're talking about cannabinoids potentiating the immune system. All right, so we've gone the entire hour. We don't really have a lot of time for Q&A, but I want to finish with this. We want to talk about the clinical implications, right? Should patients and clinicians consider cannabis when undergoing immunotherapy? Eloise.
You know how I'm going to answer that, right? It depends. And I think, this is one of the biggest questions I get when patients are undergoing, immunotherapy and want to use cannabis. It really becomes a discussion around benefits versus risk. And, I really want patients to go through a thorough health history and evaluation to determine if the benefits are going to outweigh any potential risks of them using, cannabinoids during their immunotherapy treatment. And most importantly, I think really, for me, it's not a black and white issue. And that's the discussion I like to have, because I think often when we see this kind of research, particularly in cannabis, because we're still maturing as an industry, the research is constantly evolving. We tend to be very black and white in our approach when we see research like this. And, I've made a couple references to COVID because I've seen a lot of this happen during COVID when people were getting ready to get the vaccine. They were really concerned about whether or not they should continue their cannabinoid therapy when they were going to get the vaccine. And, there were some people that were coming out saying, absolutely not, do not use cannabis, it's immunosuppressant. And other people that were saying, well, you can continue your therapy if you've already been using it, but maybe don't start a new cannabis treatment. And that was sort of where I tended to the camp that I was in, because again, it is biphasic. I think that the research we've presented today really does demonstrate the bidirectional effects of cannabinoids, and we don't fully understand what dose is going to cause these responses. So, at this point, if you're going to use it, please work with a healthcare professional who understands cannabinoids, and also immunotherapy that can guide you safely and effectively to use it. And if you need to stop, that's the good news that we see with cannabinoids, is that when people do stop, usually within 3 to 5 days, the majority has been expressed out through the urine and feces, and there's no long-lasting effects. I don't know. I think we have a couple minutes for questions. Tim, what do you think? You're muted. It's always one of us.
We have about 4 minutes to the top of the hour. So we do have a couple of questions that are in the chat. I'm just going to start from the bottom, so apologies to those who put a question in earlier. Question from Stephanie: do you think they could prescribe medically for pain control someday for ESRD? I don't know what ESRD is.
End-stage renal disease. Yeah, absolutely. I mean, I think, the majority of cannabinoids are being metabolized through the liver and not the kidneys. And I've certainly seen some patients successfully use cannabinoids for end-stage renal disease. I think the bigger issue really is, when will we get healthcare professionals educated enough and confident enough in cannabinoids to recommend it as a first-line treatment? We've got great research to demonstrate that cannabinoids are effective in chronic pain in adults, yet it's often either not recommended or recommended as a last-ditch effort when everything else has failed. So, patients deserve choices and they deserve to be informed.
Great. I just want to remind everyone that Heidi has put some additional, thank you, Heidi, some additional links in the chat. So to some information about this topic and to some studies, I think. Let's see. Would you recommend no cannabinoids with PD-1 and PD-L1 inhibitors like Keytruda and pembrolizumab?
Keytruda, yeah, right. Pembrolizumab. I did practice today.
You're undergoing anti-PD-1 and anti-PD-L1 inhibitor, checkpoint inhibitors. What do you think?
Again, it depends, Liz. Sometimes I will say absolutely not. I take many things into consideration, like the stage of their disease, the potential response rate of, their disease with the immunotherapy. What are their side effects that they're having or symptoms that they want to treat? Are they having quality of life? Are they able to treat those things? Again, for me, it comes down to making sure that their symptoms are well managed, and having those really open, transparent discussions with them about the research and helping them, presenting the information to them so that they can make an informed decision with, sort of a shared informed decision. So I never say no. I always say it depends.
So we are pretty much at the top of the hour. So I'm afraid that we're not going to get to some of the questions in the chat. I do want to say that, please reach out to us if you do have questions about the community webinar today, info@radicalhealthcare.com. Reach out to us and we'll start a conversation via email. I did notice that 1 or 2 people joined here at the top of the hour. We did start at 4 p.m. Pacific time, so we are actually finished. But we are, and then somebody asked about the PowerPoint presentation. We don't release the PowerPoint slides, but we do record this and we will post it on our YouTube channel. So just go to Radicle Health or go to YouTube and just type in Radicle Health and you'll find our YouTube channel. And you can rewatch the presentation there. So thank you all for attending. We had a really nice turnout today. We appreciate that. We know it's late on the East Coast. And we'll be back in a month or two with another topic. If you have any suggestions, don't hesitate to reach out. any questions about the curriculum or Radicle community. And then also, I do want to say that we are going to have another protocol coaching session, protocol guide coaching session with Eloise on September 13th. So you can go to our Thinkific site and sign up there, or you can just reach out. We can let you know how you can sign up.
It's going to be on neuropathic pain.
It's going to be on neuropathic pain. Thank you. So reach out if you have any questions about that, and we'll see you all soon. Great to see you.
Well, good to see everybody. Thanks for coming.